Assalamu alaikum. Welcome back to my channel. Today our topic is mitral regurgitations. Mitral regurgitation not just an murmur at the apex. It's a silent condition that can completely change the way the left ventricle remodels and how long a patient survives. Sometimes it begins with nothing more than palpitations or shortness of breath, but if missed or underestimated, it can lead to heart failure and sudden decompensations. Today we are going to break down mitral regurgitation in a way that practical, visual and clinically useful. In this session we will cover three essential things: mechanism, that how to separate primary from secondary mitral regurgitations, echocardiography assessments from jet appearance to quantitative measures like Vena Contracta, PISA, infective regurgitation orifice area, and regurgitant volume, regurgitation fractions. Clinical essential making: when to manage medically, when to repair surgery, and advanced therapies like mitral cleft may be considered. Let me ask you a question. If you see an eccentric wall hugging MR jet on color Doppler, can you grade severity by jet area alone, or do you need quantitative parameters? Hold that thought. We will assess it together shortly. Now, first of all, we should need mitral valve anatomy and leaflets. Anterior and posterior leaflet each have three scallops, like anterior A1, A2 and 3 scallop from lateral to medium, as you see in the image below, and posterior P1, P2, P3 scallops. These are 6 scallops of the mitral leaflet. 3 are the anterior leaflets and 3 are the posterior leaflets. And the annulus, the junction between atrium and ventricular, and the place where the mitral leaflets inserts. There is an anterior and posterior portion of the annulus corresponding to the respective leaflets. The anterior portion is attached to the right and the left fibrous trigones and the structurally more supported. The annulus may dilate leading to functional regurgitations or calcify leading to stenosis. Subvalvular apparatus: papillary muscle, anterior lateral and posterior medial. The anterior lateral papillary muscle usually receives dual blood supplies from LAD and circumflex artery, where the posterior medial papillary muscles usually has single blood supply, either circumflex or RCA. Chordae tendineae, primary, secondary and tertiary cords connect the papillary muscles to both valves, leaflets. These can elongate, shortens, ruptures, calcify or fuse. Ventricles: the ventricle size and shape impact the function of the mitral valve. As the ventricle dilates, it becomes more spherical and the papillary muscles become apically displaced and can restrict the closure of the mitral leaflets leading to MR. So this is the anatomy and the components of the mitral structure. This is the schematized diagram, and this is the echo diagram of the mitral leaflets and divide into scallops. And the short axis view mitral level, all the 6 scallops are seen. The upper is the anterior A1, A2 and A3 scallops, and the lower is the posterior P1, P2 and P3 scallops. As well as we see the A2 and P2 scallops in parasternal long axis, and the 4 chamber P1, A2 and A3 scallops, and apical 2 chambers P1, A2 and P3 scallops are seen. Mitral regurgitation can be divided into two basic categories: primary MR and secondary MR. Primary MR results from disease with intrinsic abnormality of the mitral valve apparatus like mitral valve prolapse, rheumatic heart disease, endocarditis. As you see in the image, there is a vegetations on the leaflets and also abscess like cavity which is perforated, and congenitally clipped mitral valve leaflets. The secondary or functional MR, the primary abnormality is not the mitral valve apparatus but at the surrounding structures, and the MR develops as a secondary problem like ischemic heart disease, dilated cardiomyopathies, hypertrophic obstructive cardiomyopathies. These two major categories of the mitral regurgitation are primary MR and secondary or functional MR. MR due to mitral valve prolapse. Mitral valve prolapse is defined as systolic displacement greater than 2 mm of one or both mitral leaflets or scallops into the LA below the plane of the mitral annulus. As you see in this video clip, the posterior mitral valve leaflet is prolapsing into LA and leading to severe eccentric anteriorly directed jet MR. The best view is parasternal long axis view for the mitral valve prolapse, mitral regurgitations, and the color Doppler shift of mitral valve prolapse usually eccentric either anteriorly or posteriorly. MR due to rheumatic heart disease. In patient who develops carditis with acute rheumatic fever up to 50% can have valvular heart disease later in life. Mitral valve is the most commonly involved valve with the rheumatic process. Mitral stenosis is the most common lesions. Mitral regurgitation is less common. There may be mixed of MS and MR. As you see in this clip, there is also MS and MR mixed lesions. MR result from shortening, rigidity, deformity, and retractions of the leaflets, and shortening and fusions of the cardi and papillary muscles. MR due to infective endocarditis. Infective endocarditis can result in MR by perforating valve leaflets. Vegetations can prevent leaflet coaptation, as in this case there is a vegetation on the posterior mitral leaflets, so that can prevent the leaflet coaptations and leading to severe mitral regurgitation and acute mitral regurgitations. It may lead to rupture of the cardi, paravalvular leakage in case of prosthetic valves, valvular retractions during the healing phase. MR due to clipped mitral valve leaflets. Clipped anterior mitral leaflet is combination with primum ASD occurs in partial AV canal defect. Clipped mitral valve is best seen in parasternal short axis view, as you see in this image of the short axis mitral level, and the anterior mitral valve is clipped. I also shared a video previously on clipped mitral valve and subaortic ridge. I will give link in the descriptions. Now, secondary or functional MR due to ischemia. This is the case of regional valve shape normality with mild to moderate mitral regurgitations. Ischemia can lead to transient papillary muscle dysfunctions or ruptures and acute mitral regurgitations. Chronic MR can result from retractions of the posterior mitral valve leaflets due to retractions and scarring of the posterior middle papillary muscles secondary to chronic ischemia. Secondary or functional MR due to dilated cardiomyopathy. In this case, you see the moderate MR and the dilated left ventricular and left atrium. DCM results in dilatation of the mitral annulus and incomplete coaptations of the mitral leaflets and central MR. Secondary or functional MR due to HOCM, as you see in this case, there is septal hypertrophy, cardiomyopathy, systolic anterior motion of the anterior mitral valve leaflet result in posteriorly directed eccentric MR. As you see in this case, there is a alveoli obstruction with mitral regurgitations. Assessment of severity of MR and echocardiography. In addition to identify the cause of MR, echocardiography is equally reliable in assessing the severity of MR. There are certain findings which are supportive of significant MR, while the severity of MR can also be assessed by semi-quantitative and quantitative methods. Supportive LA size and LV size. Semi-quantitative methods are jet area, continuous wave Doppler signal density, mitral E wave velocity. Quantitative methods: Vena Contracta, regurgitant volume, and regurgitant fractions. 2D assessment of MR: assess the functional anatomy, assess the LV size and functions, assess the LA volume, assess the right heart chambers. Color flow assessment of MR: jet area, jet and LA area ratio, direction of flow, central jets, eccentric jets. Color will also guide Doppler exams. Look at this. This is the jet to LA area ratio methods. And in this method, we trace the jet area, which is 8.6 centimeter squares. Then we trace the LA area, which is 22.9 centimeter square, and then we divide the jet size into the LA size, and this will give us the percentage. Less than 20% is mild MR, 20 to 40% is moderate MR, greater than 40% is severe MR. Now in this case, the 8.6, the jet area divided by 22.9 in the LA area is equal to 37%. So this is called moderate to severe mitral regurgitation due to continuous wave Doppler assessment of MR. The density of the Doppler jet is proportional to regurgitation volume. Like in this case, there is a faint incomplete Doppler signal. This is a mild MR, and the dense Doppler signal parabolic shape will be severe MR. Assessment of pulmonary veins flow in MR. Normally, in the pulmonary vein, the flow will be toward the probe and positive deflections. Whenever there is a negative Doppler shift, this is called retrograde systolic flow reversal, which is an indication of a severe MR. You see in this video, in this image, this will be a reversal flow in the pulmonic vein. The negative Doppler shift occurs, and also in this image you see a negative Doppler shift. In the normal well and the normal flow, there will be a positive Doppler shift. No negative Doppler shift will be seen, but in this case, the severe MR, there is a negative Doppler shifts. This means that there is a flow reversal in the pulmonic veins. Quantitative methods for assessing of severity of MR. In first, in quantitative assessment, there is a Vena contracta. You see in this video, we have measured the narrowest neck and the flow conversion zones mere in four chamber or peristernal lung axis. Use standard color scales. Measure the width of MR jet at the narrowest point, as you see in this clip. Measure just below flow conversion zones. If there is a zero point 0.7 centimeter consistent is with severe MR. And less than 0.7 will be considered as moderate, or less than 3 is will be mild. The limitations of vena contracta are multiple jets and are eccentric MR. These are the limitation of vena contracta where vena contracta methods doesn't work. Now we take regurgitant volume and regurgitant fraction by continuity method. Continuity equation works on the principle what comes in must go out. Measurements which are required: alveoli diameter and velocity time integral, mitral valve annulus diameter and velocity time integral. First of all, we calculate stroke volume at alveoli. First we measure alveoli diameter. Alveoli diameter we have 2.2 centimeter, as you see in the video. Stroke volume formula I have diameter square, which is 2.2, multiplied by constant, which is 0.785, multiplied by 9.4, which is velocity time integral, you see in the video. I am tracing alveoli VTI. There is 9.4 velocity time integral we have. You see in the video there is 9.4 centimeter alveoli VTI. So the stroke volume of this patient is 35.7 milliliter. Now we calculate stroke volume at mitral valve. First we measure the mitral annulus diameter. The stroke volume of the mitral valve formula is diameter square, which we have 4.4 centimeter of the annulus diameter of the mitral valve. Then we multiply it to a constant, which is 0.785, then multiply by mitral valve inflow VTI, which is 16.9 centimeter. As you see in the video, I am tracing mitral valve inflow VTI. There is 16.9 mitral valve inflow VTI 16.9 centimeter, and our mitral valve stroke volume is 256 milliliter. So the regurgitation volume of the MR formula, the stroke volume of the mitral valve is 256 milliliter minus stroke volume of LVOT, which is we have 35.7 milliliter. So the regurgitation volume of the MR is equal to 220 milliliter in this case. And the regurgitation fraction formula is regurgitation volume, which we have in this case is 220 milliliter divided by stroke volume of the mitral valve, which is 256 milliliter. So the regurgitation fraction is 85%. Limitation of the continuity equation method is unable to use with multiple regurgitation lesions, as in the one patient we have AR and MR also, so the continuity methods doesn't work there, and multiple shunts like VSDs, etc. Now regurgitation volume and effective regurgitation Orifice by PISA method. Use apical 4 chamber or 2 chamber view. Optimize 2D image. Shift color baseline in the direction of flow. Set Elysium velocity varies from 20 to 40 centimeter, as you see in the video. Here is 26 centimeter. Then measure the radius as I did and calculate the regurgitation flow as you see in the video. My machine gave me the required data by its software setting, but here for you here is the formula of regurgitation flow. Formula of regurgitation flow is equal to a constant number, which is 6.28 multiplied by a radius, which is in centimeters. Here we have the radius of this PISA is 0.9, as you see in the video, 0.9 centimeter radius we have. So we multiply it to velocity of Elysium, which we have as 0.26 meter per second, is equal to a regurgitation flow, which is 125.83 milliliter per second. So this is the regurgitation flow. Now we calculate effective regurgitation orifice. For effective regurgitation orifice, in the first step we calculate the regurgitation flow as it 125.83 meter per second milliliter per second. In the step 2, the regurgitation flow divided by the regurgitation velocity. In this case, we have the regurgitation velocity. We trace the mitral regurgitation velocity, mitral regurgitation jets, which we have the regurgitation velocity is 5.82 meter per second. So the regurgitation flow, which is 125.83, we divide in 5.82 is equal to the effective regurgitation orifice, which is 0.22. This is the
effective regurgitation orifice, which we take from the PISA methods, and the regurgitation volume, the effective regurgitation orifice multiplied by the VTI of the MR, which is 194.2, is equal to 44 milliliter. So the regurgitation volume in this case is 44 milliliter. Now take a note of the parameter of severity of MR. Effective regurgitation orifice less than 0.20 is mild, and greater than 0.4 centimeter square will be severe, as well as the regurgitation volume less than 30 milliliter is mild, greater than 60 milliliter is severe, and the regurgitation fraction greater than or equal to 50% will be severe. The vena contracta less than 3 mm will be mild, and greater or equal to 7 mm will be severe. Jet area ratio less than 20% is mild, 20 to 40% is moderate, and greater than 40% will be severe. So these are the parameter of the severity. Take a note of this. And thank you for watching and subscribe my channel. Thank you.